My name's Maureen Boyd. For those of you who don't know me, I'm a GP in Coogee and I'm a member of the Antenatal Shared Care Advisory Committee that kind of helps coordinate getting these things up and running with the help of the PHN and all the crew at the Royal Hospital for Women who support us so much in our obstetric and gynae education. Just some housekeeping before we get started. There are bathrooms on level 0 and level 1. If anybody needs to use the bathroom, just make yourself aware of the fire exits, please, before we get going. There's one at the top and down here. I also ask you not to eat and drink in the lecture theatre if we can avoid that, please. Just remember at the end of the session to complete your evaluation forms and particularly to make note of the topics that you would like covered. We take great notice of the topics that people put in terms of organising the next meetings. So if you can really put some thought into any areas of interest that you think would be valuable to cover so that we can look at the consensus of opinion and try and address that following meetings. I'd like to on behalf of the South East Sydney Local Health District, acknowledge the Aboriginal and Torres Strait Islander peoples of the Dharawal, Gadigal, Wangal, Gwagal and Bidjigal peoples as the traditional custodians of the lands we operate on. We pay our respects to ancestors and elders past and present. The South East Sydney Local Health District is committed to honouring Aboriginal and Torres Strait Islander people's unique cultural and spiritual relationships to the land, waters and seas, and their rich contribution to society. To kick off today, I would like to introduce you to Professor Andrew Bissett. He's the Royal Hospital for Women's Medical Co-Director, who's going to welcome everybody on behalf of the Royal Hospital for Women. This will be the last time Andrew operates in this capacity, as this is the last time he will be still on staff at the time of these meetings. He's been doing it for about 14 years, I think we established. So we're very, very grateful for his contribution to our education. Thank you, Andrew.
Thanks very much, Maureen. And it's very nice to be here, as usual, to introduce yet another one of these GP shared care education sessions. It is the last one that I'll be doing. I resign, emphasis on resign, not retire, June the 30th. The reason for that resignation is that, basically I just need to have a rest, slow down a bit, make sure that my wife, doesn't get driven crazy by, some of the, crazy hours, etc. All of those things. And so I've enjoyed my time very much here at the Royal Hospital for Women. And it's quite funny, in about 97, I remember, doing in Newcastle, doing a lot of on-call, etc. And a fairly wise midwifery friend of mine comes up to me and says, Andrew, how long do you think you'll be able to last thrashing yourself around like this, And I thought to myself at the time, well, how long, Well, there you are, and I have done it for a while, but those words still ring in my ear, and at a certain age, I think you do have to slow down. But anyway, so on that note, I just wanted to thank all of you for your friendly cooperation around GP shared care. I've always found the dealings with the GPs very constructive, friendly, in the best interests of the women. I've always enjoyed the shared care meetings. It's a complex setup that we try and run, but there's always been goodwill from GPs, their various representatives, and particularly with Maureen and co. And so I'm always been very appreciative of that, and I've enjoyed that. In obstetrics at the Royal Hospital for Women, all I can say is that I've never had a dull moment. And I say that in all honesty. Yeah, there are some times, unavoidably that are trying testing in the various capacities, but seriously, it's been a very enjoyable time. And again, I thank you for your part in that. I do wish you a very good afternoon of education, and I would like to talk up the program. I think it's excellent, covering important areas from really experts in the area on all fronts. You've got, perinatal mental health. We've just got an excellent team. You've got Antonia Shand with her expertise around infections, medications in pregnancy, diet, and a few procedural things, and really that's been, I'd have to say, one of the great things about working here is that you've got these very strong departments, and it's always been such a pleasure to see them working together in the best interests of the women. So on that note, again, I would like to thank you all for your friendly cooperation over the last 14, 15 years, and I wish you a very beneficial afternoon of education. Thank you.
So folks, just for those of you in the room, just to remind you that we do have some online attendees today. So some of this is for their benefit. If you have questions online, you can click on the question and answer button. If you type your question into the box, we will be moderating those questions as they come in, and we'll try and pick an opportunity to either bring all those questions at the end of the speaker's talk, or if we think it's poignant to what's being spoken about, we may interject. So just be aware that we're monitoring your questions, but they may not get immediately addressed. We may try and find an opportunity to slot them in. For those of you in the room, I suppose we will probably try and keep the questions to the end, and unless it's something that's really like life-ending sort of stuff. So just from that point of view, also to remember that to stay a part of the program, you need to keep 12 points over the triennium, the 3 years. They don't all have to be CESPN activities. They can be external activities as long as they meet the requirements of the antenatal shared care program. Remember that CESPN can't see what you've done. So if it's stuff done outside of CESPN specific programs, you need to let them know what you've done. And the email address to forward that documentation is right there on that slide. So it's ansc@cespn.com.au. So to start off today, we're all starting to use the e-referral system via HealthLink, and we're very lucky today that we've got, as part of our comprehensive program of education that we're providing to you, we're very lucky to have Kristen Marari from the Engage Outpatient Site Change Manager, who's going to discuss with us the electronic referrals program and hopefully be able to answer any of your questions. Clearly we haven't been using it for long, and there's obviously things that are teething problems, and I suppose the things are only going to get better with time. So we're very grateful to have Kristen here to help us today. Please welcome Kristen.
So, and team.
And team.
I'll go first since I'm the boss. My name's Arun Sapag. I'm the project manager. Along with myself, I've got Kristen and Mitch, who are the change managers. And I've got Laura and Claire, who's our executive sponsor. That's part of our group. So in terms of just our overview or our agenda, everyone's familiar with e-referrals. So we'll do a recap. We'll explain exactly what services are online and what services are going to be planned for this year and anything else that we've got covered in the slide. So we might as well start. So in terms, oh, that's tiny. Okay. So in terms of just a recap, what is e-referrals? So e-referrals are part of an Engage Outpatients program. That is a partnership between eHealth and Ministry of Health to enhance the patient journey through the digitization of referrals and the referral management process. It consists of 2 programs. The first one you're quite familiar with, that's the electronic forms available by HealthLink. The second one is the ERMS, which is the internal hospital software that we manage and that we run. So in terms of background, when we first presented, we presented stage 1, which was the pilot at Prince of Wales, centralised outpatients. Then because that was successful and got a lot of feedback, so we went into stage 2, which was further expansion to Prince of Wales, Sutherland and the Royal, which you're part of and you're familiar with. And this slide pack covers stage 3, which we got approval, I think, at the end of last year. So this stage 3 will go into next year. So it's an 18-month program. So these services are online now. So there's just, I think those brochures are at the back or up at the top. So these are currently available to you. And also at Sutherland, we've got those specialties. Moving forward, what's planned for this year? So the items in red, or the services from in red, are going to go live on the 28th of May. Okay, and the rest on the left side from St. George go live from the 25th of June. Okay, and for phase 3B, that's from July onwards. So that's right now yet to be confirmed, but we're talking about those services and hopefully we can get them online. This slide I'll hand over to Kristen.
Thanks all. We've come a real long way in the last 18 months of our deployment of electronic referrals, and we've really embarked on that journey. So we really like to thank you as referrers for coming on that with us and engaging and adapting to that change. To date, we've received close to 24,000 e-referral submissions. So we do thank you for that engagement. Royal Hospital for Women are doing exceptionally well. They are really moving away from that paper-based referral pathway and really focusing on that electronic referral process. Sutherland is doing great too. It is a significantly smaller service than we do offer here at the Royal and Prince of Wales. Prince of Wales, we're at 50%, but we do know that there is room for improvement, and we have heard your feedback as referrers of having those more services come on board to make it a much more streamlined process for you. We do know that since the deployment of electronic referrals in 2023, we know that referrals across the current services offering electronic referrals are being actioned within 7 days or less. So we know that this is a really significant milestone, because your patients are getting, the referrals are being triaged clinically in an appropriate time, and appointments are being made, and they've been obviously or put on a wait list, and we're communicating with you and the patients as well. So the grand plan is for across the district. We really want to move away from that paper-based referral pathway, and e-referrals will be the preferred method through HealthLink, through accessing through your practice software, or through the My HealthLink portal if you don't have access with integration with your practice software. Just a few troubleshooting items that just to make you aware, you may or may not be aware. The first one is if you're a referrer who works across multiple locations, so multiple practices, within your HealthLink profile, it actually defaults as a main surgery. So therefore it doesn't allow for the facility to get a real indication of where that referral originates from. So it is a process of just updating your profile within HealthLink in regards to that practice. The second one is in regards to the patient identifiers. When you're attaching those attachments, those test results or x-rays through HealthLink, a part of that electronic referral. Again, this is a in your profile in HealthLink. If you don't have the header and footer icons set up, it means those patient identifiers for those results that you're sending doesn't attach. So therefore it could lead to a clinical risk. So we just do ask if you can have a look at your HealthLink settings just to ensure that those two items are obviously aligned with what we need to better handle the referrals and obviously clinically triage appropriate. I guess the other biggest one that we have seen, and a lot of feedback from the Royal, there is a significant number of results that are required to be submitted a part of a referral if you're referring in for antenatal. If you have those relevant documentation available to you at the time of the referral, we do ask you to provide that supporting documentation. It just allows us as a facility to clinically triage your referral in a more appropriate time. Otherwise, we would be putting your referral on hold and asking for that relevant supporting documentation if we can't proceed. So we do ask, if you have the ability and you have that information, please submit it at the time that you do have the referral. You've also got the ability to update a referral. So if extra information does come to hand 1 or 2 days or so forth after the date that you've submitted, you have the ability to update that referral with that additional information as well. So you can have the ability to do that. The old results.
Yeah, so I'll click on attachments.
Yep.
Come back to my most recent,
Yeah.
investigation results. But how do you scroll to get older investigations?
So all the investigations that come across into HealthLink is actually from your practice software system.
Yeah.
So it would, I'm not entirely trained in the GP practice software systems. There would be a way that you would be able to expand on that, but that would definitely, the information would be there. If it's attached to your patient record in your practice software, you should be able to locate that to be able to attach. But yeah.
So being able to update, I think, is a bit of news to us because we've kind of had to be generating a new referral.
Mhm.
So could you just talk us through what that looks like?
Yeah. So when you submit a referral, initially launch the HealthLink, you're going to see, you come to the HealthLink homepage. You'll have basically at the top, you'll have two tabs. It says make a referral and update referral. So if you have an make a referral, that means you're actually sending a brand new referral with the information, and you're commencing the journey of that patient's referral into, say, the Royal. If you do have an opportunity that you've raised a referral, say today, and on Monday you receive the blood results back from SEALS or wherever that blood results may have come, you have the ability to go into that referral that you've raised today and update that with any other supporting documentation that you need to make. And that automatically comes across into our system, the electronic referral management system, and that alerts us to tell us that there's an update, and then we action accordingly. It does obviously save a little bit of time in regards to that. You have the ability to do that. It is an enhancement that has come recently. Yes. No, it's correct. That's exactly right. It comes in. It doesn't affect the access to care. It all comes in and it is actioned accordingly as a whole. Yeah. Yeah. Yep.
Price too much for me. Send it.
Yep.
So I'll take that off, send it,
Yep.
and I'll try and go to the
Update.
update and put
Yep.
it in that.
Yep.
And still saying too much memory.
Okay.
So then I have to print it out, email it, or fax it
Okay.
to the clinic, and hopefully they.
Put it together.
Yeah.
So that's a health link. We'd have to investigate if the site, there is a size limit on regards to the results. And from what your example would be, it's maybe the size limit of that file. Potentially it could be if there's multiple results in one file, maybe breaking it up depending on how you get your results in your practice software and so forth. Yeah. HealthLink can definitely help you in regards to that. This is HealthLink, they're the vendor of this, and they house all the e-referrals and the functionality of sending it across. So if you do have any issues in regards to sending or size issues, they are the first point of call, and they should be able to assist you. If you do have any issues in regards to HealthLink, just please let us know, and then obviously we can escalate from a district point of view. Yep. So we have, leads on to the next slide. So we're the Engage Outpatients project team. So at the moment we are currently embarking on stage 3. So we are formed, there is 4 of us a part of this team at this present stage. These are our contacts at this moment. In regards to that, if you do have issues, you can reach out to us directly. Alternatively, if you want to reach out to the service, and identify and obviously reach out to Chantel or Wade. They can they can escalate to us. They know how to get us quite quickly. So we can obviously resolve any issues that needs to be addressed with HealthLink. If we don't know about these issues, then we can't raise it to HealthLink. We think everything is okay. We're going out and promoting electronic referrals. As you can see, we're doing quite a substantive expansion. The plan is by the end of this year, we're going to have pretty much 95% of outpatient services onboarded. So we really want to engage with you. We need you as the referrers to obviously refer electronically, but we really want to make it a more streamlined approach for you. So we know and understand there's a hybrid referral pathway at the moment. We know that some services are accepting only faxes or emails or electronic. We understand your frustrations, and that's why we as an engaged project team, we're working on that to onboard as many services as we can.
To bring the actual copy of the results, whether they were still attached to the referral, do we need still copy to the patient?
No, if we have the results at the time of referral, we should be able, we wouldn't need them to bring it on the day. Yeah. Yeah.
No, that's really.
That's it.
Yeah.
Thank you so much.
That's okay.
One of the really helpful things that we've already struck today that I think was news to me and I think completely different to what we discussed this morning is the update facility. So guys, that now opens up the opportunity to add more data to the referral once it's been sent. So that is your morphology, your NIPT results, your oral glucose tolerance tests, the 28-week results. You can add it all, so it'll all end up in the patient's file at the hospital end. So that's a great addition. No.
Updating.
Yeah.
Because updating
Yep.
apparently doesn't mean.
No, but it does. Yeah, but it does mean that, you know, if between that referral and their first appointment at the antenatal clinic of 14 weeks, you may have NIPT results or you may have an early GTT for some reason, you know, there may be something relevant. To know now that we can update that referral and it's flagged as updated, I think is really helpful. Yeah, they triage it through.
They triage it. So if an update comes through, it flags to. If an update comes through, it flags to us as users, the end users, to say it's a red banner basically in our system to say stop. We need to do something. There's something happened with that referral, and we need to action that straight away. So that's where it would be identified that you've included extra results or any additional supporting information that would be looked at clinically. It's the nursing
staff.
Nursing staff.
So the nursing staff who triage the referrals anyway. Yeah. That's who's that? Chantel, who triages?
Danny's up. He's popped up at the back. It's a dash. Yeah, correct.
Yeah, and then they come around to us and say, what do we do now? Do we need more information? We see you have a who, so yeah, they come around talking to us and the more information you put there, it's very helpful. Thank you.
Okay, brilliant. Thank you guys. Thank you for
Thank
that.
you.
Really, really
Thank you
practical.
so much. Thank you.
So we've learned something new already. That's great. So now I'd like to introduce Isabella. Isabella, you're going to have to help me with your surname. Jraj. Isabella is going to speak with us about the Get Healthy in Pregnancy program that we, in the intake this morning, we touched on its existence, and Isabella is going to give us a little bit more information on how we can utilise it for our patients. Thank you, Isabella.
So thank you everyone for being here today. So I'm Isabella. I'm a health promotion officer within the Equity and Prevention Service, which sits in Population and Community Health, a part of South Eastern Sydney Local Health District. And I first really wanted to say thank you to CESPN and the Royals Antenatal Shared Care Liaison Midwives who have been really supportive in having our presentation here today, but also getting the word out about Get Healthy in Pregnancy to our antenatal shared care GPs. So I'd first like to do an acknowledgement of country. So CESPLIT acknowledges Aboriginal and Torres Strait Islander peoples of Dharawal, Gadigal, Wanjigal, Widjigal and Bidigal people as the traditional custodians of the lands we operate on. We pay our respects to ancestors and elders past and present. CESPLIT is committed to honouring Aboriginal and Torres Strait Islander people's unique cultural, spiritual relationships to the land, waters and seas and their rich contributions to society. And I wanted to pay my respects to any Aboriginal or Torres Strait Islander people in person or online today. So what is Get Healthy in Pregnancy? So Get Healthy in Pregnancy is a free, healthy lifestyle program. It's a New South Wales health program operated by Diabetes Australia on behalf of New South Wales Health. And it's free health coaching for women who are pregnant, but also preconception, birth and beyond. The health coaches are university qualified health coaches, so they'd be speaking to a registered nurse, a dietitian or an exercise physiologist, and they're there to provide support to the patient reach their health goal and throughout their journey. So as you can see on the screen, they can be referred for a range of different reasons. So healthy eating, physical activity, reaching a healthy weight in pregnancy, alcohol abstinence in pregnancy, but also postnatally in breastfeeding, and connection to other services. So if a woman discloses she's smoking or vaping, they can refer to Quitline. Patients can reach their health coach in lots of varieties of ways, and the most popular being on the phone or via online, so a telehealth conference. There's also a patient portal where they have access to resources, webinars, further information, and they get motivational text messages throughout their journey and also post the completion of the program. Now, I know this slide looks like a lot of information, but it's really to show what a pregnant woman's journey through Get Healthy in Pregnancy would be. So they get up to 6 to 10 health coaching calls. This woman was referred for nutrition and exercise support during pregnancy. And the health coach, what do they provide support in? So helping set SMART goals, identifying barriers, and developing strategies to overcome them. So it's really about supporting a woman and making those changes and it being what she can do in the capacity of her own life. And really normalising rehabs and setbacks. So that's going to happen. It's going to happen within the journey for everyone, but there to support how do we overcome them to then meet our goals. So I wanted to draw your attention to just a few health coaching calls. So for example, in call 2, you can see that the woman has said she tried to do some pelvic floor exercises and struggled and couldn't do them. Then there's a follow-up in call 3 where the health coach provides that information. It's really practical and she then gets support in how to do those pelvic floor exercises, then to continue on in their pregnancy. Call 5 as well. Again, it's very practical. So making healthy meals to cook them and to freeze them. So when the baby's born, they can reheat them. And within those, they'll get healthy recipes where it makes sure that all those dietary considerations and extra nutritional needs are included in those meals. In terms of outcomes, so just to draw your attention to the outcomes, so at completion, there was increased fruit and vegetable intake and a decrease in discretionary foods. This process can also occur postnatally too, and anyone can be referred over the age of 16. So now you know how great the program is, you're going to want to know how to refer your patients. So you can refer through clinical softwares, so through Best Practice or Medical Director or Health Pathways. You can also refer through the Get Healthy Service website. It's a very simple referral form. Or you can also call that direct clinician line. So if you have any questions on a patient's eligibility, you want to follow up on a patient's progress, you need to refer or ask any questions, call that direct clinician line. You won't be waiting in that general phone line, and you'll be speaking to a medical advisor or one of the health coaches. Patients can also self-refer. So we had some great brochures at the front, which you can give your patients, and we'll also be sending things after today, but that has the Get Healthy Service website on there and their phone number. So a patient can call that phone line or refer themselves. Something I did forget to mention, but in terms of the health coaches, there's also bilingual health coaches that speak Cantonese and Mandarin. And the Get Healthy service also utilises the translating and interpreting service. There are also Aboriginal health coaches, one being a woman and one being a man. And they also have support services specifically for Aboriginal and Torres Strait Islander people. In terms of what happens next after you've referred a patient, so the patient will receive an email or a text message within 1 business day letting them know that they've received their referral. A patient will be called within 2 to 3 business days, and then they can start their health coaching journey. So there is no wait lists for this program. In terms of the clinician or the health professional, within the referral form, you can receive patient progress reports. So you can receive how they're going throughout the program and receive outcomes of their progress. So you can receive that at the enrolment, the middle, and at the end or the completion of the program. You'll also receive updates if they've withdrawn from the program for whatever reason, and you can call that clinician line as well to follow up on patient's progress. Again, you need the patient's consent to do that. Once you've referred, you'll get an email within 1 business day letting you know the referral's happened, and then that's it. In terms of the resources available, there's quite an extensive range of resources that you can physically hand the patient of more information about the service, and also a good reminder for yourselves as the service is available and some information that you can give your patients as well. So there is resources in multiple languages. So we've got it in English, we've got it in Chinese simplified and traditional, Hindi, Vietnamese and Arabic, and there are also Aboriginal and Torres Strait Islander resources available. These resources can also be ordered, so they can be ordered via the Get Healthy service, or please get in contact with me and we can order them and get them delivered to your practice. So I really wanted to say what my role was and how we can support antenatal shared care GPs. So my role is to really support the local implementation of the Get Healthy service within South Eastern Sydney Local Health District. Now, if you don't fall into the district, we definitely still can support and put you into the right contact information with the other LHDs. Our role is to support promoting and the awareness of the program, to assist in any barriers that may arise, and to answer any questions or provide feedback back to the Ministry of Health and back to Diabetes Australia. And what that support looks like, so we can be delivering training, webinars, in-services for your practice, sending those relevant information, providing updates when they happen, and answering any questions that might occur. So I was going to say that's my contact information. So please, if there's anything related to Get Healthy in Pregnancy, please email me. I was going to say if everyone has their phone, could they please scan the QR code? And it just asks a few questions around Get Healthy in Pregnancy that would be able to support us and support you. But that's it for today. I would love to answer any questions while you guys are scanning the QR code, and yeah, thank you.
Thank you. We're very lucky to have the access to these services for our patients. And thank you, Isabella, for coming and making us more aware of how to utilise them better. Thank you very much.
Thank you.
Next speaker. Hey. So Our next speaker is Dr Antonia Shand. We're very lucky that Antonia is coming to speak to us today about infections in pregnancy. Antonia is head of maternal fetal medicine at Royal Hospital for Women and is a maternal fetal medicine obstetrician at the Royal Hospital for Women, and a research fellow at the University of Sydney, running an infections in pregnancy clinic, multidisciplinary high-risk antenatal clinic, perinatal loss clinic, and undertaking prenatal ultrasounds and prenatal diagnosis in the maternal fetal medicine unit. Thank you, Antonia, for giving up your time for us today.
So 40 minutes.
Yeah.
Excellent. Hi, thanks everyone. Thanks for having me. I've got a grandmother who was a GP. My aunt's a GP. I sort of grew up spending a lot of time in general practices, and I did try general practice and thought it wasn't for me. So now I am an obstetrician, and I think that's easier than being a GP. So the brief today was to talk a bit about infections, but I'm also going to recruit you for some research and talk a little bit about a few other random topics that I'm quite interested in, and I thought you might be interested in too. So I'm sorry, I'm telling you I'm going off brief. My first thing I thought we'd talk about is about CMV, because there's a lot of it around. I have seen so many people in the last month who've got CMV infection in pregnancy. I think there's a lot being transmitted in the childcares in Sydney at the moment. And so you're going to see these women, and it's really important that you know what to say, because it does really cause problems in terms of learning problems, hearing problems, cerebral palsy, stillbirth, miscarriage, whole range of problems. And it's actually really common. And talking to women, a lot of women have never heard of it. And they don't know, and then they go, when I see them and say, well, it's actually really common, they go, well, how come no one ever told me before now? So we're trying to get the message out there that this virus is circulating in our community, and children often commonly are passing it to their mothers when they're pregnant. Now, it's particularly an issue, I think, in women who have grown up in Australia or other high-income countries, because we know they're less likely to have had the infection in childhood, while over on the community, about 40% up to 50%. But women who've grown up in countries of low and middle income countries are way more likely to have had the infection before. And a number of women will seroconvert in pregnancy. You can also get reactivation or reinfection, and that can sometimes be a bit difficult to tell. And it's really a significant number of births in Australia who are being affected or infected by CMV every year. So herpes virus, so just like the chicken pox and the with shingles and with cold sores, it does have this reactivation. So the fetal effects, as I said, many children are completely well, don't have any problems, but hearing loss, intellectual impairment, cerebral palsy, seizures, and perinatal loss. So the kind of referral, I saw a woman, oh my goodness, I'm going wild now. I saw a woman like, oh, I don't know what I'm doing now. Sorry about this. So the kind of typical referral that I see is a woman in her second pregnancy who has a child in childcare, and usually she's a bit unwell, and an astute GP will think, this might be a viral infection. They might do EBV, they might do CMV, you might do whatever you think you need to, but then they come back and say, with a CMV positive. But sometimes people will do a full blood count and do some liver function tests, and that should also provoke going on testing for CMV. And then what happens is then they will get referred to me. And then I will talk to them and say, well, they say, well, how did I get this infection? And it's usually from the small children, but you can get then, it can be sexually transmitted, but also this vertical transmission, what we're worrying about. And 30% of children in Sydney have the virus, and they excrete it for a long period of time in their urine. So when a woman has the infection for the very first time in the first trimester, that is the worst time to get it. And about 1 in 3 women will pass that infection to their unborn baby. And of those unborn babies, about 1 in 3 will have a problem from it. So overall, about 1 in 10. But the later risk
infections, later trimester infections are much less of an issue. And as is non-primary infection, about a 1% chance. And this is way more common. And I think when you're used to interpreting serology, so you know that the IgM goes up first and then the IgG goes up second, and then the IgM will come down, but it sometimes will take a very long time to come down. And this is the problem about interpreting serology when you've got somebody who's IgM positive and IgG positive. You're like, when did they have the infection? And you all know that the key thing to do is look at the CMV IgG avidity to try and determine when somebody had the infection, because that really matters. So do an avidity. And if you've got some serology from before, do avidity earlier, because if they've got high avidity, I can say you had the infection 12 weeks ago, and depending on how pregnant they are, worry or not worry. Chase any previous results. Booking bloods are stored. When you do your booking bloods, they are stored by the lab. That's a NATA requirement. Then you have, we'll always go and ring the lab and say, have you got it? Dig them out, test them in parallel. And then if you think this patient has primary CMV, send them to see me. That week, I want to see them because we need to talk to them about therapy. There is therapy now. So the two ways you can tell if somebody's got primary infection is about seroconversion. So they've gone from IgG negative to IgG positive. And so if I'm seeing women pre-pregnancy, I will test to see if they've ever had the infection before, partly because it leads to a conversation about what is this virus, but it also gives me something to compare with in the future when they get sick in pregnancy. Or the other way is they've got IgM positive, IgG positive, and low avidity. And just remember, the positive IgM doesn't really mean anything. It could mean early infection. It could mean cross-reactivity. It could mean nothing. So this is from the RANSCOG, just to interpret the serology. And you can see if you're IgG and IgM positive, it's really about that avidity to determining how recent the infection is and then what to do with it. If they're IgG positive, alone, then that means they've had past infection without an IgM. And this is really just saying about when you get the infection really matters. That if you get it in the periconception area, then that's less likely to be infected, but more likely to be severe. And in the third trimester, the risks are much lower. So in 2023, there was a big meta-analysis after an RCT showing that valacyclovir, very high dose, 8 grams a day, reduces the risk of mother to fetal transmission from about 1 in 3 to about 10%. So, but you need to give it early, and you need to give it in the first trimester, and you need to monitor the women closely, because there's about a 1% chance of them getting renal impairment. It's a huge pill burden. Our hospital is kindly funding it for women. It's now on the hospital formulary, because if you write scripts for this amount of valacyclovir, it's very expensive for women. So we will offer people who've got primary infection in the CMV in the first trimester therapy. And then we will talk to them about, well, is there fetal infection? When can you tell that there's fetal infection? Unfortunately, amniocentesis can only be done around 20 weeks. There is a proposal we might be able to do some CVSs to look at early trimester, but we look at doing ultrasounds to look if there might be effects, serial scans, MRI, to determine whether is there fetal infection, is there fetal effect, and then what do families think about this information. Would they want to stop a pregnancy? What's the role of therapy? And then about follow-up, and what's the risk of, role of treatment later on. So we are recommending all pregnant women are given information about CMV infection. Hayley Smithers-Sheedy from the Cerebral Palsy Alliance has done an amazing job with some resources that are freely available. She's got a little booth out there. She's giving away free resources, but you can, for those people who are online, you can order them. She'll post them to you. They're free, and about getting information. They've also got some amazing leaflets, because often people, want to know about if they have CMV infection, what does it mean? And so they've got great resources for that as well, that we all using around Australia to make sure we've got the messaging right. And there's also a CMV support group. So just in summary about the CMV, it's common, there's limited awareness. We're trying to educate everyone. We're not recommending screening at the moment for CMV. However, we think it's coming. It's become routine in Europe. There are a number of countries that are recommending routine screening, but we want to know your opinion about this. I've got a survey. I'm trying to recruit you guys to my research about what you think about this, because it's not quite clear when to screen, how often to screen, and what the referral processes are. So it's coming, but we want to know about workforce readiness. We want to know about what women think and what and how we're actually going to manage this. There are some vaccine trials that are coming along, and also different types of screening trials, best ways of giving information, and please complete my survey. So moving on to a slightly different topic. Last year, I saw a whole lot of women with toxoplasmosis, but I haven't seen any this year. People who've got toxoplasmosis, it's, they've gone and eaten raw meat. Somebody working in a fish factory, vets with, little kitten poo, people who've unclean water supplies. So I think the take-home messages are that, for women need to be cooking their food, cooking their meat, high quality water if they can, and also about just be careful about changing cat litter, gloves, preferably washing your hands. And there's quite a lot of apparently in kangaroos and raw pigs. So it's less of metropolitan Sydney, but if you've got patients who are out shooting game, and that's an issue. There are things about food safety, about freezing meat, don't drinking unpasteurized milk, don't eat raw meat, oysters, mussels, wash your hands, and gardening as well. Again, if you've got somebody who was suspected toxoplasmosis, repeat the serology. The serology interpretation is very similar, but the problem with toxoplasmosis is the IgM will stay positive for sometimes months to years. So it can be really difficult to untangle sometimes whether somebody's actually had toxoplasmosis in pregnancy. So if you believe you're going to screen your patient in pregnancy, please screen them before pregnancy with an IgG only. And same with CMV, if you want to do it before pregnancy, just do an IgG only, because it is just a nightmare, these IgMs. And you'll be coming to me and I'll go, oh, you're making my life hard, because I don't know what to do. You can always talk to your reference lab. They love calls from all of us. Again, just about this, how to interpret the serology, about, positive, but again, just doing an avidity. And then again, if people do have toxoplasmosis, we will talk to them about therapy, about either spiramycin or pyrimethamine and sulfadiazine. Again, we'll just follow a surveillance and investigation pathway with amniocentesis, ultrasound, and talking to families about outcomes. Again, it can cause major intellectual disability with abnormal brain. So it is important to know. But there's really not that much here compared to other countries where we're eating raw meat or with poor quality water supplies. I will give you the resources for the ACID guidelines. There's a book, a perinatal infection book. It's a free download. It's really good. It's got all the pathways when you can't remember what to do and how to interpret serology and which infections to worry about. I mean, people ring me up all the time and I just say, let's pull out the book together. We'll just go through the flow sheets. It's really an excellent resource. We will, the hospital pharmacy will fund it. It's quite difficult for people to get spiramycin and pyrimethamine. So just if you've got people with toxoplasmosis, please, we're happy to see them. I guess the question people ask me is, which infection should I test in pregnancy? I mean, I think you all know about, we are recommending, screening for hepatitis B. We're testing for hepatitis C. We're testing HIV for all women. We're testing for syphilis for all women. Obviously, we're testing for rubella, but there's very little rubella here in Australia anymore. CMV and toxoplasmosis are not recommended tests. But if you think somebody's unwell, I mean, you guys are out there seeing unwell people all the time. So you know way more about what's in the community than I do. But toxoplasmosis, it's lymphadenopathy, often CMV viral symptoms, a raised white cell count or LFTs, fatigue, myalgia, and just do the testing. But they're probably the main ones to worry about. I guess rashes, I mean, you guys are all over rashes. I mean, you know what a parvovirus rash probably looks like more than I do. Measles, syphilis, I guess, you know, vesicular rashes, if you think you've got chickenpox or herpes, and, you know, you can do testing for that. I guess, you know, viral symptoms. So listeria is a pretty uncommon scenario. If you think you've got somebody who might have listeria, you're obviously going to send them into us. And there's quite a good guideline there from the UK about, you know, what to test and how to test people in pregnancy. But I guess the main things are, you know, these are the main infections we're worried about, got fetal effects about the parvovirus, the syphilis, the CMV and the toxoplasmosis. I guess if you've got people with abnormal ultrasounds, then you're going to send them to us in fetal medicine, and then we will work them up from there in terms of high drops or brain abnormalities or echogenic bowel, I mean, growth restriction and stillbirth. We will just go through the paradigms for that. Basically, torch screening, please don't do one. I've spent my life telling people, please don't do a torch screen, so you can just forget about that now. I'm still training some of my colleagues out of it because you do a lot of unnecessary testing. If you've got somebody with parvovirus, I mean, it's flat cheek infection that often if half of women who've been exposed to it at home will seroconvert, and that can cause fetal anemia and high drops. So if there's somebody's got a parvovirus infection in pregnancy, we will do surveillance with ultrasound. Because of this high drops, and then we can sometimes do a fetal transfusion if the fetuses get anemic. So there is therapy available. In terms of chickenpox, so there's not so much chickenpox around at the moment, but obviously taking a history. I think you all know about zoster immunoglobulin. So if you've got women who are not immune and not vaccinated and exposed to shingles or chickenpox, that you need to get zoster immunoglobulin, just call us. I think it's quite hard to get hold of. Last time I was like, I had to go the roundabout where to get hold of it, unless you know, I think we have to get it from the blood bank. But it's something you need to do quite urgently. And obviously you advise people not to go and sit in a pregnant, you know, in your waiting room with a whole lot of other pregnant women if they've got chickenpox, if they get the infection. And then if they get the infection, we'll start them on acyclovir. If late in pregnancy, it's an issue with the chickenpox because obviously the newborn baby can get the infection as well. How much time have I got here? We're okay? Okay. So women who there is a small number of women out there in the community, as you well know, who are varicella non-immune, who've just managed to avoid getting the infection and are too old to be vaccinated in the program. So we do recommend women who are planning pregnancies do get vaccinated pre-pregnancy. It's obviously an issue because a lot of people, it's not funded. And those women who are non-immune, because a lot of people are getting their varicella tested in pregnancy for those women who are non-immune and non-vaccinated, because you know the serology, you can be fully vaccinated but still doesn't look immune on your serology. That, you know, advise them if they get in contact with a rash that, or shingles or chickenpox, that they should seek urgent advice. And then obviously if they get the infection, then seek urgent attention. I think you all know there is a syphilis epidemic going on in Australia. I think you'd have to be under a rock to not know there are lots of babies dying in Australia from this infection. So I think we have increased the screening to twice in pregnancy. But I think if you've got anyone who's got any signs or symptoms or potential risk factors for it, then do another syphilis test. Because early diagnosis and treatment makes a difference. And I think I'm on the National Living Evidence Guidelines, which has got a number of consumers on the guideline development. It's a really interesting process, but it's quite interesting talking to the consumers. They're like, oh, I don't need to have this testing done, or no one I know would need to have this testing done. And there's just, a lack of awareness that it's not necessarily what you're doing, but the people you're having sex with, what maybe they might be doing. And so I think the more testing we do, the more likely we are to make some more diagnoses. And it's coming from the north, from the west, and from the south to us. And we've been very lucky so far, but there's more coming.
Screening during the
Yes. Yep. We recommend all women get at their 28-week bloods, have their syphilis testing done. 2 point. Everywhere else in the country is recommending screening at 36 weeks as well, or birth, whichever comes first. New South Wales is an outlier on this, and there are national guidelines saying that we should be, but we haven't moved there yet. So expect there's going to be even more syphilis testing coming. And if you've got somebody with suspicious syphilis, please call somebody urgently because they obviously need treatment. Don't be reassured by the negative serology and use the perinatal guidelines. I mean, you presumably will call sexual health or public health, or you can call us, just pick up the phone, call someone, and we can get them in for treatment. This is just showing, these are the latest graphs about the epidemiology of the congenital syphilis, the epidemic in Australia. Just showing 99 cases, 20 cases in 2023, and 10 deaths. And 80% of people who the babies died were diagnosed late in pregnancy. And I think when you look at the epidemiology, we know that men who have sex with men are a big proportion of the syphilis cases around the country, but and Aboriginal and Torres Strait Islanders are disproportionately have higher rates of infection, and the remote and very remote have got high rates, but it's everywhere. Yes.
Is there any
Yes, yeah, quite a lot of it. And so these late cases are people who've actually acquired the infection in pregnancy. And I think, when I go to these national meetings and people, about taking a history, and people say, well, I didn't have sex with anybody different. And it's like, well, hang on a minute. What is the definition of sex? It could be oral sex, anal sex, vaginal sex. Just because you haven't had vaginal sex doesn't mean you're not having sexual activity with somebody.
Ask any questions. Would you mind repeating them just because
sure.
People aren't picking them?
Okay, sorry. The question was, well, 2 questions. One of them was, should we be testing everyone at 28 weeks? And the answer is absolutely yes. And then are women, the babies who are dying because they have acquired an infection in pregnancy? And the answer is yes. So that's why test opportunistically at 28 weeks, and somebody who you think might have risk factors, who've got multiple sexual partners or traveling, or partners, might be at risk, just test again. And obviously symptoms, I mean, you guys, it's not something you've probably seen very much in terms of what does syphilis look like, in terms of the painless chancre or the rash of tertiary syphilis. So it's not common, but if you think somebody's got, it's very infectious, is just test again. People can have reaction to the penicillin. Penicillin is the treatment, so we do need to think about, particularly in pregnancy, for people who are really penicillin allergic, can we do a desensitization? And we need to contact, we need to find the partners, trace, test, and treat the partners. And I guess we're just some reminders for us about, if women are turning up unbooked, we need to make sure we've got some urgent results. And I guess, you may be in the situation where you might have a baby who's actually presenting to you with syphilis and it hasn't been ticked up. So the rhinitis that can happen. At the abnormal teeth. So I guess if you've got an unwell baby, again, thinking about syphilis. The treatment, it depends on when you got the infection, whether it's latent or primary, or you're not sure. It's about how many doses of penicillin you need to give. So, but penicillin is the answer. Somebody put a question, one of the briefs was talk about GBS. I guess the party line is that GBS can cause a range of infections for mother and baby. I guess the reason why we're screening for it is for early onset group B strep sepsis. About 20% of women have the bacteria in their vagina. And this is just showing in the red line the early onset group B strep sepsis rates falling when you do screening. So I know that for a lot of women who don't want to have antibiotics, that's they will choose not to do screening. But I think it's important that they know what this, the risk is low, but we know that by screening and treating, we do reduce that risk. But in early onset sepsis. The LEAP is the living evidence for pregnancy and postpartum guidelines. They're currently under revision, but they do give some just important tips about, discussing prevention, just giving information about why the test, and just explaining about, why to do it and what we're going to do with it. So it's just a normal bacteria. The risk is small. But antibiotics does reduce that risk. And we also would recommend women stay in hospital for 24 hours so that the baby can be observed for signs of group B sepsis. Another question, people have been asking me is about just herpes infection as well. So we just take a history for women who've got recurrent genital herpes. If you've got women with lesions, obviously you're going to test them, and it depends on whether it's primary or not primary infection and when they've had it, about what the management options are. So this is just from the ACID guidelines. And if you've got women with recurrent herpes, we would recommend giving suppressive therapy if she wants to have a vaginal birth, and that suppressive therapy is from 36 weeks. Not sure why I'm selling you vaccinations, but I'm selling vaccinations to everyone, pre-pregnancy vaccinations for people who are not up to date. And, before the pregnancy, I think you all know about the RSV vaccine that's gone live with funding. So we're now recommending all women have RSV vaccine from 28 weeks, flu vaccine and whooping cough vaccine. And this is just the guidelines from New South Wales Health. There are some quite good resources. I know there's a lot of vaccine hesitancy out there in the community, and this group has got some very nice websites and videos and things for people with vaccine hesitancy about, the why are we trying to do this. One of the issues we're having at the moment is we've got very low hepatitis B immunisation for babies. We're about to do a quality improvement project looking at clinician attitudes, information giving, women's attitudes and knowledge to try and improve hepatitis B vaccine. But we're also going to do some surveying about other vaccines as well. So this is the ACID guidelines, that perinatal infection book that you can get a free download. It's excellent. The LEAP guidelines, they've got a website. That's the fetus phone. So if you've got fetal referrals or you don't know, you can call, and you just want to ask somebody, call it. That's our midwives. That's their hotline. They'll take a referral from you, get some more information and see if they can solve it or call you back. After asking one of us, and there are just some other guidelines. This is a really great course for those of you who want to learn a bit more about infections and pregnancy, about syphilis and CMV particularly, and this was Hayley and the cerebral palsy team and the whole group from around the country developed this infection and pregnancy course for GPs, and the QR code, it's not here, but we can distribute that afterwards. I thought it was on here. It's from Prax Hub anyway, and it's free in download. Recruiting people for women who are planning pregnancies for the pre-babe study. So this is an online pre-pregnancy health coaching, and that's for women with a BMI greater than 25, and it's either health coaching or meal replacement. And this study will complete this year, and we're looking at pregnancy outcomes. So for those women, it's a virtual trial, so they don't have to turn up in person. They can be anywhere in New South Wales in the trial and planning to have a baby. I think that's the end. My other thing is just about, we are part of this preterm birth prevention initiative, and we are, I know you've all had a lot of education about making sure we measure the cervical length. Part of our, with these new e-referrals, we're having a little bit of difficulty identifying those women from their history who are at risk of preterm birth. So we have a preterm birth clinic where women get streamlined into a continuity of care model with close surveillance. So for women who've had past history of late miscarriage or preterm birth, spontaneous preterm birth, can you just on your e-referrals, and then they get flagged sometimes in a different pathway.
Just some online questions. Antonia, if you don't mind, I'll just come near the microphone so people online can hear.
Can you fill in my survey? Everyone online, that's the QR code. This is a survey for you guys. I want to know what you think.
So we've been asked, why are we not doing CMV serology as part of the routine antenatal screen, which you kind of touched on, but we might sort of specifically go. And the other question, I don't know whether you could answer, which is, are all antenatal blood stored in labs? Can we add these things on? Can we add on things that are relevant?
Yeah. So why are we not doing CMV screening for everyone? We don't know what women think about this. I'm concerned 5% of women, if you test their IgM in pregnancy, will be IgM positive. It's a huge amount of workload. Without a trained workforce, I'm concerned that women will be given the wrong information and terminate pregnancies who were going to have a normal outcome. So we haven't really felt that we were workforce ready for this yet. And I guess this is one of the reasons why I'm very happy to be talking to you today and want you to do the online courses. We want to know your opinion. But, you know, if people were given the wrong information, they will make irreversible decisions that might be harmful for them without a lot of benefit. So it is a bit tricky, but I think it is coming. Yes, all serology should be stored. There's a NATA requirement for that. And so when we're trying to untangle when somebody has CMV and when they've had it, yes, we will often get the lab to run the serum in parallel, so we can try and work out the when.
That's brilliant. Thank you. So yes, that question was about whether or not we should be looking at testing in the preconception stage for.
In my practice, I would do a CMV IgG alone for all women who are planning pregnancy, because when they get sick and then somebody carefully does a CMV and I go, well, I don't know when you had it, I've got something to compare with.
Mm-hmm.
Yeah, so just it's funded. Yeah, you can do it as part of your pre-pregnancy serology when you're thinking, are they chickenpox immune? Are they varicella immune? I mean, are they rubella immune? Do I need to vaccinate them? You know, Hep B, HIV, Hep C, whatever you want to do pre-pregnancy. Yes, CMV IgG alone. Do not add an IgM in. It'll make your life very painful. Well, Torch has got a whole range of other things that might not be helpful for you in terms of herpes serology. You know, if you do herpes and it's like, well, what do we do with this? Because a lot of people have been exposed to the herpes virus before but don't have symptoms. I don't think it's necessarily helpful to know that. So, you know, yeah, don't do that. But just put CMV IgG alone pre-pregnancy. It can be helpful. And if you want to do toxo screening, which I don't recommend, just do an IgG alone as well.
So that's leading into one of the other online questions, is if you have pregnant women who have pet cats, or you wouldn't routinely test?
No, there's not that much toxoplasmosis in Australia. So we are not recommending toxoplasmosis screening. So remember, screening is for asymptomatic people. We would not recommend toxoplasmosis screening. Obviously, for people who are unwell and got signs or symptoms of toxoplasmosis, that is testing.
The other question online was, would you recommend, if a woman hasn't got Hep B immunity, would you recommend that she be Hep B immunised prior to pregnancy?
Yes, that's what the guidelines say, that all people in Australia should be offered a full course of vaccinations, and hepatitis B is in there.
Mm-hmm.
But I think, you always have to look at people's, risk of hepatitis B. I'm fully vaccinated. I'm sure you're all fully vaccinated. I'm a believer in vaccines, and I mean, hepatitis B, it can be, you have to look at people what their risk factors are. But yes, that's the recommendations.
Brilliant. Thank you.
No, you can't vaccinate during pregnancy. You probably wouldn't necessarily defer the pregnancy, but I guess you can. You get some partial immunity with the first vaccine.
So it's just
catching up,
opportunistic, isn't it?
Yeah,
it's taking opportunity, I suppose. Another question. Sorry, the question was if you have tested positive, negative, sorry, for IgG in a pre-pregnancy state, is it an opportunity to look at risk reduction for the patient going forward?
Yes, particularly, that's a good question, Hayley. For those women who are CMV negative, who've never had the infection before, you really want to give them advice pre-pregnancy and about the first trimester about prevention, because it's really upsetting to me. It was really upsetting to me when one of our hospital staff who'd had her fertility treatment here at the hospital, somebody carefully did her IgG. She was negative, but no one ever told her. And then they also didn't tell her about CMV. And then she got first trimester CMV infection. So it was very disappointing to me that we had not quite followed through. So yes, educate all women, but particularly those women who've got who you know are CMV negative.
So the other thing that Chantel and I just had as a bit of a side comment, because Antonia mentioned the vaccine hesitancy for Hep B at birth for the babies. Maybe that's something we need to incorporate into our patient education in our antenatal care, is preparing them for that offer of their Hep B immunisation at birth to their babies, so that they have a bit of time to nut out some of their own questions before the day being faced with having to decide.
Yeah, and we're just, some of the other hospitals around Sydney have got formalised processes where patients are given an information leaflet and then have to sign written informed consent to say, I want to vaccinate my baby for hepatitis B and I'm going to give my baby vitamin K intramuscularly. I am not going to do these things, or I'm not decided yet. About to formalise the process to see whether that, so that's one of the things, the quality improvement projects, I'm just anticipating what we're going to start doing to try that.
Brilliant. Thank you, Antonia, for giving up your time today to come and help us with our management of our patients. It's been really relevant and really helpful. Thank you so very much.
Thanks for inviting me.
Thank you very much. Thank you very much.
For those who are in person, feel free to come talk at the break.
Thank you so much, Antonia. Always we learn so much, and we always find as many new questions as we find answers. So I'm sure there'll be things to talk to Antonia about going forward. I'd now like to introduce Meredith Stone, who's going to speak with us about perinatal mental health. Meredith is the head of perinatal psychiatry and women's mental health at the Royal Hospital for Women. Clinically, she divides her time between the Royal and as a fly-in, fly-out psychiatrist, managing a broad range of acute psychiatry presentations in the New England area of New South Wales. She's a passionate speaker and educator who has presented on a range of topics related to women's mental health, both locally and internationally. Please welcome Meredith to speak to us today.
Thank you very much. I'm hoping, do we know, is video material working today? Well, yeah. So my first question, which I'd like you to think about whilst we watch the brief video, is why perinatal mental health?
Babies this young are extremely responsive to the emotions and the reactivity and the social interaction that they get from the world around them. This is something that we started studying 34 years ago, when people didn't think that infants could engage in social interaction. And it still takes experiment, but the mother did, she sits down and she's playing with the baby who's about a year of age. And she gives a greeting to the baby gives a greeting back to her. This baby starts pointing at different places in the world, and the mother's trying to engage her and play with her. They're working to coordinate their emotions and their intentions, what they want to do in the world. And that's really what the baby is used to. And then we ask the mother to not respond to the baby. The baby very quickly picks up on this. And then she uses all of her abilities to try and get the mother back. She smiles at the mother. She points because she the baby puts both hands up in front of her and says, "What's happening?" She makes that screechy sound at the mother. Like, come on, why aren't we doing this? It's 2 minutes when they don't get the normal reaction. They react with negative emotions. They turn away. They feel the stress of it. They actually lose control of their posture because of the stress that they're experiencing. It's a little like the good, the bad, and the ugly. The good is that normal stuff that goes on, that we all do with our kids. The bad is when something bad happens, but the infant can overcome. After all, when you stop the still face, the mother and the baby start to play. The ugly is when you don't give the child any chance to get back to the good. There's no reparation, and they're stuck in that really ugly situation.
Okay. I think that's a fairly compelling answer as to why perinatal mental health. Has anyone seen that video before? Yes. Okay. I'm glad that there's some GPs who are already very attachment attuned. Obviously, we don't just want to look after our women because they're mothers. We want to look after them because they're women who are struggling. But it is a concept in perinatal mental health that we look at the dyad, and that we realise that if a mother's not okay, then the baby's not going to be okay either. I think I was maybe a little overly ambitious when I was doing my seminar outline, partly because I think traditionally perinatal mental health has meant postnatal depression. And I want to show that it's not just postnatal depression. In fact, in the perinatal mental health landscape, and I suspect that you will find this as well, the straightforward cases of postnatal depression are probably amongst the easier things to treat. And it's the other conditions, such as the personality disorders, or someone coming in with birth trauma, or the more complex, serious mental illnesses that are much more complicated. So this is what I'm going to try and cover, but I do want to make it interactive, and I want you guys to let me know what you think is most useful and what the answers that you want to have about perinatal mental health. In terms of, so as I said before, it's not just postnatal depression. So what is it? In terms of time, it's sort of variously defined, but usually means the antepartum up to 2 years postpartum. Here at the Royal, we will see women up to 1 year postpartum. Our colleagues over at the PIMS service will see women up to 2 years postpartum. As I said before, it's not just the mental health of the mother, it's also the mental health of the infant. And very much these days, we're looking at the continuum between the antepartum or even before, so preconception, and the postpartum, because we realised at some point that if we get in early and if we recognise the women who are at risk of developing postnatal mental health issues, we can actually prevent at least some of the cases and ameliorate others. And we have, sorry, can everybody hear me well enough online as well? Should I move? Should I use this?
Okay.
Sorry, everybody can hear me? Yeah, okay.
People ask questions, if you wouldn't mind repeating the question.
We'll do, yeah. sorry, I just missed my train of thought there, but so the point is that we can prevent many conditions. And what I was going to say is that we have quite a comprehensive screening at booking here at the Royal, where we have the ANRQ. I don't know whether anyone's familiar with that. So it's a questionnaire that was developed by my predecessor, Prof. Mari Paul Austin, and it's basically sort of what we would do in more detail in a mental health assessment on one page. So it's not just looking at things like, mental health history, but also has questions like, are you a worrier? Do you like to have things organised? So looking at the things where we know that would make a woman vulnerable to distress in the postpartum. So the mental illnesses that we encounter in the peripartum here, and that certainly all of you would be encountering, range from the common depression and anxiety to things like adjustment disorders. Does everybody know what I mean by an adjustment disorder? Yeah, so some people nodding, some people shaking their head. And I think that it's perhaps something that is useful for GPs to know about, because basically it just means that you get some kind of mental health symptoms in response to a major life event. Arguably, anyone who doesn't have an adjustment disorder after a baby is born probably is not really getting it. But I think from a GP's perspective, it's good to remember that women can present with depression and anxiety, sort of milder forms, and that for many women, that may just be an adjustment disorder. And what they might need mainly is reassurance, fixing of some feeding routines, some sleep routines, their social supports, and then a few weeks later, they actually end up being okay. Then we have all of the other conditions really that we treat. I was thinking except maybe dementia at any other time of a woman's life, although if they've had a vascular event during birth, then dementia could also be an issue. But yeah, I think it's just important for us to remember that all these conditions will affect the pregnancy and mothering, but also in turn, being pregnant and being a mother will affect the management of these conditions and the likelihood of relapse. In terms of normal transition to parenting, again, I think something just to keep in mind, and normal here is in inverted commas because normal involves quite a lot, as I'm sure you're aware with your patients and for anyone here who's a parent as well. And so it's all the changes, like the physical changes and the sleep deprivation, but also particularly here, I think in the eastern suburbs of Sydney, we often have women who are professionals, such as doctors or lawyers or teachers, who've had a very established identity before they become mothers. And that transition to not having measurable outcomes, not having the recognition that you're used to having, that can be a major adaptation that can be normal, but still a challenge. There's a couple of other concepts here. I'm just mindful of time, so I can't go into them as much as I would like to. The psychological process of giving birth is something that I'm quite interested in. So I thought I'd just include this quote. Every childbirth is a confrontation with death as well as with life. Modern medicine can now lull us, comfort us, and soothe our terror of personal physical annihilation in most cases of birthing, but not in all. And I think this is something that we probably forget where here at the Royal, when we're dealing with childbirth every day, we're probably particularly likely to forget this, but it's something that women will experience. And I think if we can keep in mind what a major event has just occurred for those women, then we're much more able to support them without having to overly pathologise them. This is quite an involved quote, and I don't think I really have time to go into it, but the idea of ghosts in the nursery is one that I often will sort of try and convey to the junior medical doctors. If I were to distill it, what it basically means is that we were all helpless babies once upon a time, at the mercy of caregivers who were either good enough, as we like to say, or not quite good enough. And most of us in our adult lives try to avoid thinking about those times and getting on with being independent. And then when our own offspring come along, we are confronted with a being that reminds us or brings up things that we had forgotten about. If we've had experiences that were good enough, then we process this fairly well. If there are things that weren't so good, then they tend to come up in the perinatal period. And I'm not sure whether any of you have had this experience with patients, that sense of that they tend to regress around the time that they've had a baby. I'm seeing some nods. Yeah. Yeah. Okay, so to your bread and butter, just a reminder about some aspects of peripartum depression. As you can see on this slide, it's very common. There's a strong overlap with perinatal anxiety, and often, even for me, it can be really tricky to figure out, is this anxiety or is this depression? Usually there's a mix. Historically, it has been overlooked or symptoms have been normalised. These days, it can also go in the other direction. So I've found that women will be sometimes more happy to speak about having a diagnosis of postnatal depression than, say that they just are not really enjoying being a mother, for example, or that they have, perhaps some personality vulnerabilities. So for some women, having postnatal depression can actually be something that is acceptable to them. As I said before, the onset is often in the antepartum. There's known risk factors. Anyone know what some of the risk factors are? Having a baby, yes, that's a major risk factor. Sorry? Family history, yes. Unsupported environment, very good, yes. Complications in pregnancy. Past history. Work. Loss of work, yes. So you changes in identity. Yeah. Yeah. Yeah, so losses. I'm just repeating, so people online. So loss of family members, friends. Yeah, so losses in the year before giving birth or after giving birth. Yes. So all I guess the things we think about for depression anyway at any time of life, but also things like that we are not necessarily thinking about so much. So as I said before, things like obsessionality or tending to be sort of a worrier. So as I said, those kind of professional groups that we belong to, they can be more at risk. Also things like eating disorders, and there's also an association with premenstrual syndrome and generally having had gynecological issues before. Just a reminder that untreated depression tends to persist, but there is a treatment or there are sort of a range of treatments, and often in women who've been well before and have led a happy, productive life, I'm very confident when they come in and I say to them, we can get you back to the way you were. A reminder about suicide, that it's a leading cause of maternal mortality in many parts of the developed world. It's because my colleagues, the obstetricians, are doing such a good job, and the midwives. But in that context, suicide is the way women often die in the peripartum in the developed world. And so in non-Indigenous Australia. This figure of suicide being 70 to 80 times more likely in women with a severe psychiatric episode, just to clarify that. So it's not any woman is 70 to 80 times more likely to complete suicide. It's women who've been diagnosed with illnesses such as bipolar or schizophrenia. And we think that it's the association with postpartum psychosis or severe postnatal depression that can often occur in those women. So it's the usual in terms of what it looks like. It's the usual depressive symptoms that you would all be familiar with, but there's a couple of some very characteristic symptoms. Again, you've probably seen these before in your women. So the coexistence of anxiety, but also the intrusive thoughts. And that's something that I would encourage you always to ask about if a woman has peripartum depression, because those are the thoughts that are most embarrassing usually, and that they won't necessarily voice because there might be a lot of shame associated. Or if they're having intrusive thoughts of hurting their child, for example, they might be worried that you will notify child protection. And then there's a couple of other things that are sort of classic, and in any of the, there's been sort of a few celebrity outings in the past few years around having postnatal depression, and they'll invariably talk about the bond with their child. And when they talk about their recovery, they'll talk about how the bond has been reestablished, and also how they went from feeling like the worst mother in the world to feeling like a competent mother. So that kind of maternal identity theme is also very characteristic of peripartum depression. In terms of the consequences of untreated peripartum depression, again, I think probably many of you know this already. Obviously, first up is maternal morbidity, but there's all kinds of associations with pregnancy outcomes, and then outcomes on the infant, early childhood, then going on to later childhood, adolescence, and of course there's the transgenerational transmission of mental illness that perinatal psychiatrists like to think of themselves as being these godlike figures that can prevent future distress. But that's the theory is that if we get in early, then we can prevent that transgenerational passing on of mental illness. And then, of course, there's always an impact on the family unit. So on the partner, but of course that goes both ways as well, but also on the other members of the family. I don't know how many of you would probably all use the Edinburgh. What are your thoughts on the value of using the Edinburgh? Does anyone have any?
It's not very specific, let's say.
Yeah, pretty quick. Yeah, not very specific. Yeah, good. Yeah. Yeah. Yeah.
It more talks about risk to the mother and baby, I guess.
Yeah. So we've just got an audience member talking about that it's more looking at risk, and it's not particularly specific. And that's precisely what we find here. In fact, I sort of have a little bit of a rule of thumb that if someone has really high, then they probably have a personality disorder and not depression. And if they're zero, then they're probably using something during pregnancy that they don't want anyone else to know about. So on those sort of extreme ends, I get the sense that it tells me something, but it doesn't tell me anything about the depression and the anxiety. So I think, yes, it's a screening tool, and it can be a good kind of entry into talking about it. And women who are ready to, talk about the distress will rate on the scale. But if a woman doesn't want to convey anything, then she'll probably have really low scores, and just doing the Edinburgh is not going to be enough. Going back to basics, this is what you guys are probably much better at than we are, and that is, looking at the context of a woman who is presenting with depressive symptoms, particularly in the immediate postpartum. There are some feeding routines and social situations that are not commensurate with good mental health. So if we've got a woman who has been told that she has to try feeding, then expressing, then preparing a formula bottle, then, topping up, and she has to do this every 3 hours, I think anyone who is, can do basic maths will realise that that woman is probably only getting, 20-minute, if that, lots of sleep. And that, is arguably a form of torture. So I think really looking at what is the situation of the woman, and are there any really obvious things we can change? I've also, with high degree of sophistication, diagnosed a few women with low iron, basically just by talking to them, and they say they're really exhausted. And I say, well, go and do see what your iron levels are, get an infusion. They come back and they feel much better. So looking at the basics, I can't overemphasize that. Psychological, I'm just sort of looking at the time. I think we have, another 20 minutes? Or,
Yeah, we've got about 10 minutes.
10 minutes?
Or 15
Okay,
minutes.
15 minutes, okay. So I might skip over, I think psychological treatments, the main thing I want to say here is there's a huge variety in the kind of psychological treatments available. And I would really encourage you, not just in the area of perinatal mental health, but any kind of mental health conditions, to become familiar with the psychologists in your area, and the kind of different psychological treatments they offer. In most cases of perinatal distress that sort of, that doesn't pass after a few weeks, there's probably some attachment related issues from the past as well. And 10 sessions of a Medicare funded CBT is probably not going to be enough. So when I have patients coming to me and they've said, I've tried psychology and it didn't work, then I think it's always important to kind of find out what kind of psychology they've done, because if, they've had abuse from early on in life, then they won't even be able to have built the trust in those 10 sessions. Okay, I might skip over that. I'm also very mindful that we've got Dr. Debra Kennedy talking after me. Deb, are you going to be talking about psychotropics?
About ADHD medicine.
Okay, good.
Not specifically.
Yeah, okay, because I think I'm
reassuring.
Yeah, so I think I might, Deb, I send a lot of patients to Deb for them to be reassured. So she's the director of Mother Safe. I think I'm hoping that this message has kind of filtered through, that we tend to be very supportive of antidepressant therapy during pregnancy for those women who are already taking it or who are keen to start. This slide is sort of my spiel that I give, which is, firstly, that many women do use them, the antidepressants. The evidence is not as good as I we would like it to be, although I think Deb will talk about it's pretty good these days. But the available evidence is generally reassuring. And the evidence of the detrimental impact of untreated depression on mother and baby is perhaps actually more compelling than any evidence of harm. But the issue of the poor neonatal adaptation or the withdrawal syndrome, that is something that should be mentioned, but again, not overemphasised. This is, Dev, you're not allowed to answer this. So,
Do you want to go ahead and I'll comment.
Does anyone know the answer to this question? No? Okay. Yes. Why might there need to be decreased? So the answer was respiratory distress in the infant. Any other takers? Neonatal withdrawal syndrome. I might call Deb in as our expert. Deborah, do we reduce the risk of neonatal withdrawal syndrome by reducing the antidepressants before the baby's born?
The thing that probably increases it the most is because I suppose just from pharmacokinetics, that generally if you start off at the same dosing at the beginning of pregnancy, at the end, if you would do a serum blood level of whatever medication, it's likely to be a lot lower towards the end of pregnancy, and women are often come a little bit more symptomatic. So we would never say to automatically increase, but we certainly wouldn't say to decrease. The problem with decreasing is if women do become symptomatic, then people might add a second psychotropic, for example, sedate, like something like Quetiapine to help with sleep, and that does increase those risks of adaptation problems. That sort of cocktail effect. So you're better off increasing the dose of something you're already on rather than adding a second medication.
Did everyone online hear that? Probably not. I'll just they heard it. Yeah, great. Thank you. So So that's pretty much exactly what we say. So and the reason why I ask it, because I'm not sure this information has disseminated, because I think previously what was conveyed to GPs was, oh, you've got to be really cautious, and if someone's on antidepressants, then try to reduce the dose. These days, that's not what we say. So it's not, as Deb said, we won't necessarily increase the dose. If the woman is going well, then we don't. But we know that there's hemodilution in the third trimester, and that they may not be having an effective dose anymore. So we are much more likely to increase the dose than decreasing it. And so the important thing to remember is that it doesn't reduce the chance of neonatal withdrawal by decreasing the dose. What then happens is that a woman's on an antidepressant, which may lead to neonatal withdrawal anyway, and she's probably depressed or anxious. So it's kind of the worst of all options. Okay. So that's basically, these slides will be sent around, won't they? Yeah. So I might skip over. Anxiety, many of the principles are similar to depression. I guess the kind of take-home point from this slide is that you will all be in a unique position to diagnose anxiety. And I think many women with anxiety are actually much more likely to come to you than they are to come to me. And especially if they're not really psychologically minded or ready to think about having a perinatal mental illness, how it may manifest is that they're coming and they're talking about, the pregnant, they've eaten something and they're worried that they're going to miscarry. If they come once or twice and say that to you, then, that's within the scope of kind of normal worry. But if they're repeatedly coming back and worrying about, things that they've done that are going to harm the fetus, then I'd be really thinking about introducing the idea of anxiety. Postpartum, the classics are, you know, if you've got someone coming to you, baby's 2 weeks old, and they say, I think my baby may have autism, because it's sort of not really looking at me. So, you know, those kinds of preoccupations with the baby's well-being that don't really correlate objectively with how the baby's going. Although anecdotally, there is a strong association between reflux and maternal anxiety as well. SSRIs, just in my experience, are actually more effective for anxiety than they are for a kind of pure depression. So that's where we really see, you know, just sort of the edge being taken off the intensity of that experience in the peripartum. If needed, use low-dose quetiapine. Obviously, we want to try and reduce polypharmacy during pregnancy, but postpartum. So firstly, a couple of things to say on that. If a woman is super anxious during pregnancy and I'm starting an SSRI and she's not sleeping, she's not eating, then I would probably start a low-dose quetiapine or olanzapine with Deb's blessing. But also postpartum, if someone's really anxious and you can kind of feel the anxiety in the room, don't leave them hanging for 2 to 3 weeks. See whether you can do something to help them sleep. Sometimes doxylamine is enough. I don't know how often you all recommend doxylamine. We love it here at the Royal. Sort of handing it out like lilies. Okay. Bipolar disorder. Does everyone know sort of the distinction between bipolar 1 and bipolar 2 or 3 or 4? No.
Clear manic episodes of bipolar 1.
Yeah.
It's bipolar 2 with hypo.
Yeah, exactly. So so clear manic episodes with bipolar 1, bipolar 2, they haven't ever had a full-blown manic episode, which means that often, and different psychiatrists will tell you different things, but there's an overlap between bipolar 2 and personality disorders. It can be very difficult to distinguish between people who've had hypomanic episodes and people who just, you know, have a tendency to risky, reckless behaviour. The reason why I emphasise this during the peripartum is that with bipolar 1, there's a significant increase in risk of postpartum psychosis. With bipolar 2, especially if it's actually a personality disorder, that risk is not significantly increased. So for women who come in on a cocktail of medication, I think it's really important to try and figure out the difference, because if they've got bipolar 2, then I would be really looking at, do you need to be on all these different medications? Whereas if they've got bipolar 1, I'd be very strongly saying, please go and speak to Debra Kennedy and talk about your medications, because we need to have a really careful plan to prevent the postpartum psychosis. Anyone who does have a bipolar disorder, ideally they would be sent to a psychiatrist for preconception planning, and then they'd be managed by a psychiatrist. Unfortunately, we can't see them here until booking. I'm thinking about maybe doing a preconception clinic in future, so if they're going to birth here. But certainly once they've been booked, we're very happy to see them either here at the Royal or if the case managed over at the Eastern Suburbs Mental Health Service, then PIMS can see them as well. Or sometimes, okay, I've got 5 minutes. Sometimes we co-manage them. I've got 5 minutes left and then maybe a little bit of time for questions. Is there any particular condition that people would like to know more about of the ones that I put up? Yeah.
About anxiety.
Yeah.
You know, you mentioned starting SSRI. What's your threshold for sort of starting the SSRIs versus doing the sort of more, CBT and
psychologist sort of approach.
Yeah. So for those online, I think they may have heard it anyway. When do we start SSRIs? That's for anxiety. That's a very good question, and there's no hard and fast answer. The nature of anxiety is that women really worry, and so often they'll be very worried about the idea of starting a medication, either in pregnancy or if they're breastfeeding. I don't have any hard and fast rules, so I tend to be guided by the woman, and often women will come and they'll have a sense of what they want. So they'll either be really anti-medication, and then what I do is I say to them, okay, I'm just going to tell you about the medications, just so you can keep that at the back of your mind. If there's, if things get worse and you feel that you're really not coping, and then I tell them about Mother Safe, but I leave the decision for them. Sometimes I'll have women who really want to start medications and I'll feel, I'm not sure that you really need to. But even in those cases, I tend to sort of go through the risks and benefits and ultimately leave it to them. There's only, and just in terms of evidence, for mild to moderate anxiety and depression, the evidence for psychological treatments and medication is pretty much the same. Yeah, so you don't need to push either, but the only times where I really say, okay, we need to do something now is if in those cases where they're not eating or sleeping and I'm thinking, they're at risk of either physical collapse or tipping over into psychosis. And then I tend to be more firm. But I think most of the cases that GPs will see will be more that mild to moderate end. Yeah. I'm thinking I'll just quickly ask this question. Oh, sorry, you've got another question. Yeah. 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 Yeah, that's an excellent question. And I was going to reach that in the later slide. So the question is, say someone's come in on not an SSRI, but an SNRI, but I think you also said potentially medications for, say, schizophrenia or for mood stabilizers. What do we do until they can get into a psychiatrist? So my general rule is don't take women off medications that are working. The only exception, and hopefully this would be very, very rare, is if someone's on sodium valproate. But I think I'd hope there'd be very few who are on sodium valproate of childbearing age where they haven't had an explicit discussion with, say, their neurologist or their psychiatrist why they have to be precisely on sodium valproate. So Mother Safe you can get on to Monday to Friday, 9 to 5. Is that right? So that's what I would do as the first thing if you've got questions. But the general principle for SNRIs, for the SSRIs that aren't the usual go-to, so things like fluoxetine or paroxetine, where in the past there's been a little bit of conflicting evidence, and for even extending to things like lamotrigine and lithium, keep women on them, try and get them in to see a psychiatrist and get them to speak to Mother Safe. Particularly with the antidepressants, I won't change women if they're stable on something like fluoxetine or venlafaxine or duloxetine. I wouldn't think about changing them during pregnancy. Yeah. Okay.
Questions online. Would you want to do this slide?
No. Oh, yeah. Wait, anyone know the answer to this? Renal? Sorry? Fetal toxicity. There's a hint that's bipolar 1. Does anyone? Because lamotrigine is something where we're less concerned about it than lithium. So why would we not just put everybody on lamotrigine? Mania, good. What's the difference between lamotrigine and lithium? So lithium has anti-manic properties. In fact, we think it's probably one of our best anti-manic agents. Lamotrigine doesn't really have anti-manic properties. So it's not going to prevent a manic episode or a postpartum psychosis. Okay, I might go the two questions online. Yeah.
So two questions were all antidepressants safe, which is preferred in pregnancy?
Yeah, so I think I think everybody heard that. It's pretty much what I answered up. Yeah. So most of them, there's not, Deb, are there any where you would say stop it immediately?
No, absolutely not. And I think that, I mean, there's the SSRIs obviously have been around longest. Personally, I mean, the problem is the categories, and that's confusing, but really, and you said it, but if someone was on paroxetine and stable, even though it's category D, we would never say go off it. Because really that's the most important thing that people learn. If they're well and controlled, that's the most important thing.
Can't say pregnancy. It's really interesting.
Look, I think if they're well, I mean, I think that's the issue. So I think there's this sort of natural thing that, and people get concerned because some antidepressants, you know, they look at the category, and I mean, most of them are C, and C is not about birth defects, it's about adaptation problems. And then some people are more comfortable putting someone onto a B3 because B can't support setting the alphabet. No, but B3 actually says, well, there's not much human data, which is also not necessarily true, but the drug companies haven't updated that. But actually B3 says it can cause malformations in animals, the significance of which is not known in humans. So that's not reassuring. But I can't tell you how many calls we get from people being switched to C, from the C to a B3 because they think that's better. And you know, we would do it based on, obviously, on the psychiatrist's advice and how well the woman's going. And she's, well, you know, it's kind of, why fix something when it's not broken?
The patient insisted though, which ones would you recommend?
So it's already
most people get started on sertraline. I mean, the other advantage of sertraline is down the track. It's probably the least amount in breast milk. But you know, it's not necessarily the best. And there's no point putting someone on something that doesn't work, but in inverted commas speed of safety. I mean, and I think that's the problem.
Yeah, I was just going to reiterate that. I mean, I think if you had someone, you know, coming in with anxiety symptoms, had never been on anything before, is pregnant, then I think sertraline or escitalopram are really good options because we think that they're anxiolytic. Yeah, but so if you're wanting to start something, but otherwise just keep going, whatever they're on. Did we have another question?
I think the thing is, a lot of tricyclists actually, as a group, are very, I mean, they're tried and true. They've been around for a long time. So if people are well and stable on tricyclists, you know, there's probably not a good reason to stop them either. And that's like some of them with brain side.
Yeah.
Is that the same with things like valdoxin and Brintellix, like the newer?
There's not much
information about valdoxin. We're actually trying to do stuff. Another state, we're trying to follow people up on adrenaline. Also, because it's not available in the United States, so there's loads of data coming out of the States. I mean, so far it's our data's limited but reassuring, but we don't have long-term data.
Yeah. The other question was, are there any other risk factors for postpartum psychosis?
So yeah, postpartum psychosis, if they've had a previous postpartum psychosis, if they have bipolar disorder, so those are the sort of main ones. If there's a family history of postpartum psychosis, yeah, or a history of psychosis. Yeah.
Studies of use by someone.
I think that's yeah, that's sort of a more broad question in terms of generally in psychiatry. They don't really, there's a lot of hope. It's more that if someone has not, so sorry, the question was, are genetic studies are they valuable in starting someone on an antidepressant? If someone has had a bad reaction because their CYP450 enzymes, they've got sort of a weird profile, it's more about tolerability than efficacy. That's a very good question. So, as I said, we haven't started a clinic here yet. There is a loophole, and that is if they're gynae patients at the Royal for whatever reason, then I can see them for preconception counselling. If they've got bipolar disorder, like a major mental illness, then the community mental health team, if they're already linked. But there's not really enough there in terms of people who can't afford to go to a private psychiatrist.
We see people. Well, so we often see people. So probably 50% of our patients we see in a upset clinic are planning for more, and at least 50%, 75% are going to be on psychotherapy. So that's a big volume of our patients. So we're having to see that they just need a referral, and it's all got good. Right. Oh, so they just done it just to another step. They just call another step, and then you can just get it something. Yeah. But then to another step. Yeah, but we're not there. We don't have any referral.
Thank you so much. Thank you so much, Dr. Meredith Stone.
Thank you. Thank you. I unfortunately have to run off and get my kids. So if there are any further questions, if we just ask Chantel,
yes,
and you can
emailing them in, and then we'll get them across. Yeah. Thank you so much. It was an excellent talk. So we'll have a bit of a break now. It's been a long day, a long afternoon. So we'll break for about 15 minutes, and if we could be back in here for 3:20, we've got our Dr. Debra Kennedy. All right. Hi, everyone. My name's May. I'm one of the new GP shared care advisors to the committee, and I'm a GP at Bronte, and actually worked at the hospital, at this hospital as a little SRMO many, many moons ago. And Andrew Bissett's was the consultant that taught me how to do my first cesarean. So anyhow, it's with great pleasure that I introduced our next speaker, Dr. Debra Kennedy, who we are very, very lucky to have here at the Royal. She trained in paediatrics and clinical genetics before completing a fellowship in clinical genetics and tetralogy at the Hospital for Sick Children in Toronto. She is the reason why we have Mother Safe, which, as many of you know, is the New South Wales statewide medications in pregnancy and lactation advisory service that is available to both GPs and patients and gives us lots of reassurance. So without further ado, I'll welcome Dr. Debra. Thank you.
Thank you. Thank you for giving up your Saturday and staying on. And it looks it was a really nice day too. It wasn't advertised. It wasn't advertised. So. Can everyone hear me okay? Is it sort of echoing or not? No. Okay. All right. So I'm just going to do an outline. I'm going to do a little bit about just a really quick background, a little bit about just preconception care, because that's something I feel very strongly about. And then the two sort of medication groups that people wanted me to talk about were the GLP-1 medications, talking about ADHD medications, so stimulants, and then if there's time, some questions. So even though we know that it's important to plan pregnancy, still over 50% of pregnancies aren't planned, and less than 50% of women take folic acid prior to a planned pregnancy. About 5% of all our calls at Mother Safe are about pregnancy planning. Having said that, probably about 50% of the people I see in clinic are planners, which is great. As you're all aware, and particularly I think in the eastern suburbs, more older women are having babies, and there's an increased chance of a baby, apart from chromosomal problems, but there's also more likelihood that an older mother is going to be taking underlying medications for an underlying medical problem. We know that it's not time for puns, but it's a growing problem of obesity in women of reproductive age. And we know that there are poorer health and increased risk factors in women of Indigenous background. So despite the fact that we know sort of what we should talk about in preconception care, there's not necessarily that much great evidence around it. And these are some interventions which were outlined by the CDC, which have clinical practice guidelines. So kind of logical stuff, folate supplementation, managing maternal PKU, so phenylketonuria, hepatitis B vaccination, rubella vaccination, smoking cessation, diabetes management, STI screening, managing hypothyroidism, avoiding teratogenic medications, alcohol cessation and obesity control. And even though this is from over almost 20 years ago, that's not really changed that much. So for many conditions, we know actually prenatal care is probably too late. So smoking cessation, even though we know it helps to reduce obesity, alcohol, substance abuse, poorly controlled diabetes, genetic conditions, which is my particular interest as well, and medication exposures. So just briefly, and I suppose just I know that's something that ideally these things are talked about in a preconception clinic consult. We also have a plan clinic where people can have a sort of one-on-one with one of our plan counsellors who actually happens to be a GP that no longer works as a GP but now works as a mother safe counsellor. So we do offer that as a free service to patients, and they probably spend about an hour with people. We don't order tests, we just refer them back to their GPs and say, well, these are the sorts of things that might be of concern. And then lifestyle, just specifically, the things that we sort of talk about are those which, again, things like work exposures and exercise and all those sorts of things, which I'm not going to go into now, but just to be aware of. So just in terms of obesity, before we get on to the actual medications, so as you all know, the BMI, which is probably a little bit of a crude assessment of risk, but we know that a healthy BMI is anywhere between 18.5 and 24.9. Obesity or overweight being 25 to 29.9 and obese being 30 to 34.9. And we know that the risks there is like a dose response. So the higher the BMI, bigger the risks. Being underweight also carries some risks, and we know can be associated with infertility, nutrient deficiencies, cardiac arrhythmias, bone health issues and eating disorders. But being overweight, we know, can interfere also with fertility, and there are significant obstetric complications and birth defects. So these American data, but pretty Australia's sort of following close behind. Almost 42% of US adults were considered obese in 2020. We know that there's increasing awareness of adverse pregnancy outcomes in women who are obese, and pre-pregnancy BMI is probably a greater determinant of healthy outcomes rather than gestational weight gain. And it's known again that the higher the pre-pregnancy BMI, the greater the associated risks. So just as so we talk about a background risk of malformation. So 2 or 3 babies out of every 100 will be born with a major birth defect, sort of background risk. And we say that that risk is doubled with women who are obese, and also women who have got pre-existing abnormal blood sugars, so either type 1 or type 2 diabetes, so not insignificant risks. So again, as I said, there's higher rates of diabetes as well as infertility, as I said, higher rates of birth defects, and as I said, up to a doubling. And there is, as I said, some evidence of a dose response. The birth defects probably most associated with obesity include neural tube defects, cardiovascular defects, other skeletal defects, orofacial clefting, abdominal wall defects, and multiple congenital anomalies. Apart from the fact that they're more likely to occur in the first place, they're also potentially more difficult to diagnose on ultrasound, because you'll get sometimes the report in a sort of euphemistic way about limitations of the views due to maternal habitus. So that's, ultrasound having to go through layers of maternal abdominal fat don't improve the quality of the ultrasound. So there's kind of a double whammy there. So just, I'm not going to go through all these, but just that there are certainly antenatal risks in women who are overweight, as well as intrapartum and postnatal risks. So babies being potentially larger for gestational age, mothers having thromboembolic disease, preterm birth, more likely to have an instrumental delivery, difficulties with anaesthetics, wound infections, postpartum hemorrhage, and postpartum difficulties, including breastfeeding, depression, more likely to get pneumonia and other chest infections. And that was relevant, during COVID and also the influenza pandemics, where women who are overweight were, and pregnant were considered to be even higher risk of ending up ventilated in an intensive care. And so some of the neonatal infant complications for infants of obese mothers include more likely to be admitted to the NICU for jaundice, requiring blood sugar monitoring, having macrosomia, having more likely to have those congenital malformations, and longer term potentially ending up also with obesity and metabolic syndrome, possibly neurodevelopmental disorders, and possibly also asthma. So ideally, again, planning pregnancy, ideally losing weight before weight optimization before and between pregnancies. And there are some good programs now, risks associated, and being aware of the risks associated with obesity in pregnancy, and stabilising weight loss, again, prior to conception, and trying to discourage dieting behaviour during pregnancy. And there's also some evidence about bariatric surgery being of benefit, but that's obviously, a significant undertaking, and routinely offering to refer people to dietetics. Important to screen for hypertension and type 2 diabetes, especially if in a previous pregnancy there's been gestational diabetes, and particularly with a family history. And type 2 and gestational diabetes are much more genetically associated than type 1 diabetes. We recommend women taking higher dose of folic acid while they're trying to conceive, so 5 milligrams, until the end of the first trimester. It doesn't need to be continued throughout pregnancy. And if they're having significant morning sickness, then just taking folic acid and iodine is sufficient in that first trimester. Obese women are also at increased risk of vitamin D deficiency, so that's something also to be aware of. So treatment in terms of just losing a bit of weight can help with fertility. And as I said, while lifestyle modifications are mainstay, some patients will choose medical and surgical treatment. And bariatric surgery is successful. The GLP-1RAs, also the new medications, have become popular. In addition to weight loss, in addition to their utility in managing type 2 diabetes. Metformin, a lot of women are on it, and it's often helpful in achieving pregnancy in women who have irregular cycles and have PCOS. It's been around for a long time, and there's really good reassuring pregnancy exposure data in not increasing risks of birth defects or other adverse outcomes. And actually, on the contrary, some studies suggest it might reduce risks of birth defects, and some studies have also suggested a reduction in miscarriage. So it's certainly not a medication that we would tell people to come off when they're trying, or even in the first trimester of pregnancy. Having said that, if they develop diabetes during pregnancy, then metformin is not the drug of choice, and then they generally switch to insulin and should be referred to the diabetes or the medicines in the obstetric medicine clinic at the Royal, and they've got the diabetic educators and everyone here. But metformin's a good drug. Also supposedly prevents dementia, just by the way, down the track. And so we're going to get on to the GLP-1. So that's glucagon-like peptide 1, and it's an endogenous hormone that's secreted by the L cells of the small intestine in response to intake of food. So the hormones stimulate the release of insulin from the pancreatic beta cells. So it's continuously secreted at a low basal rate, so it maintains normal blood glucose, but it can quickly rise when it's stimulated in terms of when you have postprandial, when you've got a blood glucose spike. It also, endogenous GLP-1 also inhibits glucagon release from the pancreatic alpha cells, and it delays gastric emptying. So people have a sense of, being full for longer, so they're less likely to want to have food. The receptors are found in the pancreas, but also in the brain and the heart and the kidney. And it's also thought that, so it's the hypothalamic effects that are thought to also be associated with that feeling of, feeling full and contributing to weight loss. So they've also been shown the agonists, so the medications can reduce heart rate, BP, that's a blood pressure, total cholesterol, and also can improve people's lipid profile. So improving their LDL, lowering their LDLs and triglycerides. And at the renal level, there's decreased albumin excretion. So it's not quite clear what the exact mechanisms of the activation of the receptors are in the heart and the kidney. It's thought that there may be some sort of anti-inflammatory and antioxidant properties as well. So they do more than just act on blood sugar and weight. So this is just taken, so I suppose that just shows where it acts. So it's certainly acting on the gut, the brain, the pancreas, acting on blood pressure. So it's, good drugs to treat lots of different conditions. So the medications, the main ones that are available in Australia are dulaglutide, I can't pronounce them, they've got terrible names, liraglutide, semaglutide, and tirzepatide, which I think I've probably spelt wrong there. On paper, they're contraindicated in pregnancy, and that's based predominantly on animal studies because, as you know, pregnant women are excluded from drug trials, so we don't get data about pregnancy exposures except from inadvertent exposures. So there's limited human data, but there's recruitment ongoing of patients exposed. And because in some cases, these are women that have had infertility, they're taking these medications, they're not necessarily using contraception because they haven't been fertile, they're getting pregnant because we know if they lose a little bit of weight, it improves their fertility. So there's increasing numbers of inadvertent pregnancy exposures due to increased off-label prescribing, and that's not just for type 2 diabetes, but also for weight loss. And if you want a pictorial evidence of this, these are our calls just from for the last, so it's just till May 2025. And you can see, so May, so the last lot's just for this year, so not even, so it's like half a month. And so semaglutide's the purple, and the green one's Mounjaro, so the tirzepatide, and that you can see that's just going up. So but incredibly increased numbers. So these are just our calls since 2020, so huge numbers. And so the reasons, so most of the people are calling because they're pregnant. And again, semaglutide most common, but quite a few also on breastfeeding. The good news is that a significant number are planning pregnancy. And then the other ones, they're sort of miscellaneous. They're sort of, they're just either considering terminating pregnancies or retrospective, like I had a miscarriage and I took this, could it be that? So this is just a table to show just some of the pharmacokinetics. So these are the main ones I've just shown. And again, just to show you again, the dulaglutide they all have relative, so the liraglutide has the shortest half-life of only about 13 hours. So it's going to be, we say that a drug is out of your system essentially to undetectable levels after 5 half-lives. So if you say 5 times 13, so say 60, so say 3 days. So it's got the shortest half-life, and that's the one which is a daily dose. Semaglutide, again, it's got about a 1 week half-life. Likewise, the Mounjaro, so 5 days. So you're kind of looking at 4 to 5 weeks for them to be out of the system. Interestingly, some people, you know, when they're going to have surgery, and anaesthetists are saying to stop a drug for 4 days, which is kind of a bit pointless, really. So we say, look, a month. Having said that, a lot of the product information will say to stop these drugs 2 months before people are trying to conceive. But that's, if you look at that, there's not much sort of biological rationale behind that. So semaglutide is the only oral currently approved. And the actual endogenous glucagon-like peptide one has a very short half-life. It's only about 2 minutes. But the medications, they're not degraded by the same enzyme, and so that's why you've got these extended half-lives. And that means the receptors are activated for a longer period of time, so you're getting that longer duration of action. And yeah, so generally, most of them have pretty large molecular weights. So a drug that's got a molecular weight of somewhere between 500 and 600 Daltons, you will expect to cross the placenta. So some of the big medications that we know don't cross the placenta are going to be, you know, heparin, even low molecular weight heparin, and most of the biologicals. And these medications as well also have really large molecular weight, so somewhere between 3,000 and 63,000 Daltons, so really, really large. So again, from first principles, you wouldn't expect there to be significant fetal effects because they're not actually crossing the placenta at this point. We know that towards the end of pregnancy, drugs may get transferred across by a sort of active transport because things like immunoglobulins get transferred. But people will have stopped the drug. The issue is around that sort of inadvertent early exposure when we know people don't realise they're pregnant and may have been exposed, or they stopped, but within that 4 to 5 week window. So we're not expecting these medications to cross the placenta. And we expect that there would be minimal risk of direct fetal exposure. So just to clarify, just these half-lives. The Trulicity, 5 days, so estimated out in about 25 days. Saxendril, liraglutide, about 3 days. Semaglutide or Ozempic, about 5 weeks, and likewise Mounjaro. And you'll see most of them sort of, their peak probably is a couple of days after the injection. So in terms of clinical effects, they over a period of about 12 months, they on average will reduce the HbA1c between about 0.8 and 1.6%, and average weight loss is somewhere between 3 and 10 kilos over the course of a year. And some people will experience even higher weight loss, particularly those that start off at a higher weight. And again, in the setting of weight loss and HbA1c reduction, many patients' infertility may be significantly improved due to their reduced insulin resistance. And so recent meta-analysis of over 30 studies that looked at weight loss interventions and fertility found that women who were randomised to weight loss interventions were more likely to conceive compared to controls. And that was, with a significant, with a relative risk of 1 or 2. So it's likely due to a reduction in insulin resistance and increased tissue sensitivity to insulin. So a good thing. So in animal studies, mice who were exposed to these medications were shown to have decreased fetal weight and growth, delayed ossification, and skeletal variants and visceral anomalies. There was also an increase in embryonic death. But these were thought to be some people argue that a drug isn't a true teratogen unless it causes effects in a fetus without causing maternal toxicity. And so people would argue, well, this is actually maternal toxicity because mothers weren't eating properly, and therefore it was a direct reflection of maternal nutrition, maternal weight reduction and decreased nutrition. So the rats and rabbits exposed to really high doses, so there was up to 11 times human exposure, did show fetal malformations. And at 11 times a human exposure dose, there was association with early embryonic death. So that's not necessarily translatable into human studies, but there was these there were not really particular patterns of birth defect. It was more just there was possibly an increased risk of fetal loss. So with liraglutide, and as I said, dulaglutide had the largest molecular weight and at high doses. So the effects of decreased fetal weight and skeletal and visceral anomalies were seen. So again, as I said, likely related rather to maternal toxicity than direct effects. So with human data, the best we can do is case reports, case theories, and prospective cohort studies. The problem is that in these cohorts, there's going to be potential confounders because of the underlying maternal conditions. So they're going to be obese, they're going to have diabetes, they're going to have other medications, often things like statins. So we know that, you know, they're not pure samples, and that's why you've got to take some of these studies with a bit of a grain of salt. So, but basically overall, none of the human studies were particularly concerning. And if you can see here, there was one study where someone took, there was a baby with an atrial septal defect, but really not much else. And then there was one where a mother gained 35 kilos, probably because she stopped her medication in pregnancy and ended up with a macrosomic baby, and she had diabetes and the baby had shoulder dystocia, but that's probably not the medication, that's her underlying problem. So there's been a few sort of case reports and series, and basically all the pregnancies were unplanned, and people used the medication till they realised they were pregnant, up to a maximum of 17 weeks. And mostly they were being treated for type 2 diabetes and obesity, and some also for PCOS or oligomenorrhea. All cases, the drug was stopped at the diagnosis of pregnancy because of unknown fetal effects. All of the deliveries occurred after 37 weeks. There was one birth defect noted, which was an ASD. There was transient hypoglycemia, and as I said, that huge baby. And so this was another study which compared GLP-1 receptor agonists as well as other treatments for diabetes. So, and it was data from the US, Scandinavia, and Israel. And so there were 938 pregnancies, and there was not actually an increased risk for birth defects. Yep. Look, because they had very wide confidence intervals, so it still wasn't significant. But I don't know. I mean, part of it was a small number for one thing. So yeah, I mean, I suppose that's just data. But overall, it's still, even the crude risk wasn't significant. But that's just numbers, I suppose. It's also, you know, you can spend hours at meetings where people, how you define a birth defect. So it's all just, you know, a little bit dodgy, but overall not. So what can I say? So yeah, and they compared things like metformin. And then there was these other studies. So these studies looked at lots. So there was 6 countries. So that was over 51,000 pregnancies, as said, and then 15,000 were treated with these medications. And so they were things like metformin, insulin, and there were, as I said, 938 with these medications. So really, adjusted relative risks were comparable, suggesting no elevated risk of malformations after the use of these medications compared to insulin or in patients with type 2 who required medication. So again, that's just showing the same thing. So really just showing no significant differences. And again, looking specifically at cardiac malformations versus birth defects overall. And again, not particularly exciting, which is good. And this is a study, we actually contributed stuff, and then I won't even go why they wouldn't include our stuff, and it was because of ethics, because we didn't have ethics approval to call up women and say, how did your pregnancy go? Anyway, it's another story. But anyway, this was from a group. So teratogen information services like our own in Europe, and and also Israel, I think, was included. And they they followed up. So prospective women call up a service like Mother Safe, I'm pregnant, took this, what happens? And then ideally they, and in this, I can't remember if they used controls or not. So yeah, they basically looked at malformations in 3 separate groups. So yeah, they had pregnant patients exposed to these medications in the first trimester, of which there are 168. They compared them with disease-matched controls who were diabetics and people who were overweight. So saying, look, it makes sense because these are people who have possibly similar underlying kind of risk factors. And they excluded people with known chromosome problems and congenital infections. And really reassuring in the sense that there were 3 malformations, but they weren't a pattern. So one was a heart defect, one was a renal defect, one were multiple anomalies. And the rates of birth defects were pretty similar in all the 3 groups. Except for the rate in the overweight obese group, 3.9%. And again, that could reflect, as I said, poor diabetic control, and it's saying that's promising, but that they were saying that the rate of defects in the diabetic group is lower than expected, possibly implying some sort of bias. But whatever it is, I think the results from the medication group were reassuring. So I think, in summary, I don't know if I've got a summary. No, so I think in summary, we'd say, look, obviously you encourage people to come off them, but if someone is inadvertently pregnant on these medications, we would be reassuring, but they need to be monitored and referred appropriately, particularly if they have got type 2 diabetes. No, I mean, not unless they've got, if they're overweight, I mean, I think not just per se, not just, your woman with a BMI of 20, you should be telling her to take a multivitamin with folic acid and do all the right things. We wouldn't be saying to do metformin. Some of the fertility, I mean, I think the reproductive medicine people we hear were doing studies on looking at metformin in women with recurrent miscarriage. I'm not aware of what was published. So there's certainly in the fertility data there is, but I just think, your low risk average woman, I wouldn't be. Yeah. So the next one's just about stimulants, and I'm going to mainly focus on ADHD. I know that, but also mention, I suppose, that we do see women who've got narcolepsy as well, and so that we see those women as well who are on stimulants. So I'm just going to talk a little bit about ADHD, about some of the medications, and just our perspective. So I'm sure you all know it's common. It was considered previously to be very much a child condition, but it's now recognised that many of these children will continue to have their symptoms as adults, and there's also increasingly new diagnoses of ADHD in the adult population, and it's estimated that up to 3 to 4% of adults may suffer from symptoms. It's a really strong familial and genetic associations, and that's really important, particularly when it comes to doing follow-up, because, if you're looking at the medications and they're saying, well, there's a high chance that children will have ADHD. Well, it's not because of the medication particularly, it's quite likely due to the genetics. There's often coexisting psychiatric conditions, so anxiety, mood disorders, personality disorders, and then sometimes also substance use disorders. And it's a significant burden in the adult population, so it can be associated with significant functional and social disability. So in terms of education, poorer grades, requiring extra assistance, special classes, higher rates of dropout, incomplete studies, similarly with employment, so poor time management, financial difficulties, and difficulties with maintaining ongoing employment. And significant challenges potentially with interpersonal relationships, both work and personal. So more likely to have sort of health and safety issues, more likely to have accidents, higher chances of having ER and doctor's visits. So, it's a significant burden. And just, I mean, this is from America, but again, we know that the rates of use of ADHD medicine is significantly increasing in the population, and therefore in the young adult and women of reproductive age. And I think kind of what I alluded to in that first slide, we're seeing women now who are either pregnant or planning pregnancy who were prescribed stimulants as children, and they're now entering the adult, age group. But equally, a large number of women who are being recently diagnosed with ADHD and requiring medications. So again, I think, so I'll show our numbers in a minute. They're quite impressive. So the risks of untreated ADHD is certainly, and similar, I think, to some of the things that Meredith talked about before. We know that there's a exacerbation of coexistent mood disorders, substance abuse and self-medication. So rather than being stable on a medication, they're going to be using other things that may be less safe in pregnancy. Difficulties with employment, education, relationships, and accidents. So, a potentially significant burden. And so there've been sort of some studies now looking at the outcomes, and this is an Australian study, and it was looking at the outcomes of both mothers and babies associated with continuing or stopping dexamphetamine with ADHD during pregnancy. And so it was from WA, and it was published quite recently, and it was a population-based study looking at women who'd been dispensed dexamphetamine during pregnancy and gave birth between 2003 and 2018. They'd either continued to take dexamphetamine, which was a number of 547, or they'd ceased it before the end of the pregnancy, of the second trimester. And they then matched one-to-one women who were dispensed a medication before pregnancy but not during pregnancy, and that was 844. So they looked at maternal and neonatal health outcomes, and people who, the women who've ceased their medication had a higher chance of threatened miscarriage, and that was significant. And the unexposed also had some benefits compared to the continuous, which suggested a slightly lower risk of preeclampsia or hypertension, postpartum hemorrhage, neonatal special care admission, fetal distress. So continuing DEX throughout pregnancy was not associated with an increase in adverse neonatal and maternal health outcomes. Ceasing was associated with increased odds of threatened miscarriage compared with continuing. And it's something that requires further investigation. There was small sample size, and it was hard to examine miscarriages. So the unexposed showed some benefits, suggesting that where possible, the cessation of dexamphetamine may be advisable. So a bit probably not particularly helpful. So the treatment options for ADHD include dexamphetamine, methylphenidate, modafinil, bupropion, which is Zyban, which was an antidepressant that's been used to treat for smoking cessation, atomoxetine, which is a non-stimulant, and then non-pharmacological methods. Sorry? No, I didn't, because we haven't had many calls, and it's just there's not much on it. But this is just to show our calls. And again, the 2020 to 2025, again, it's only half a year. And if you look at 2000 and 2009, they're 10-year, 2010 to 2019. So we've just had this massive increase in our calls about stimulants. So these are the main ones I looked at. So dexamphetamine, so lisdexamphetamine is Vyvanse. It hasn't been around, it wasn't around before 2010, that time period. And so methylphenidate, Ritalin really increase, and dexamphetamine, huge increase. And modafinil, which is been used for people with narcolepsy as well. So some of the data. So the dexamphetamine, the old data is dirty data because it was data around abuse or recreational use of dexamphetamine. And The older data did suggest higher rates of birth defects and other adverse pregnancy outcomes. But as I said, really not clean data because most of those women were smoking, using other things, and weren't sure that what they were getting was really what they were getting. But in terms of prescribed studies, really, there's not, they've been reassuring. So studies looking at prescribed dexamphetamines have not shown a significantly increased risk of birth defects or other adverse outcomes. Again, neurodevelopmental outcomes, have been some conflicting data, but really no clear signal. And again, multiple confounding variables. As I said before, most people who are taking dexamphetamine, a lot of them are taking other psychotropics as well, whether they're antidepressants, anxiolytics. And as I said, there's other confounders, but no huge flags there either. So with methylphenidate or Ritalin, it's a centrally acting sympathomimetic. It's used in both children and adults, as well as for some narcolepsy in some adults. Mouse studies actually didn't show that it was teratogenic, but in rats, at 7 times maximum recommended human doses, there was some maternal toxicity and some skeletal variations, which is what sort of happens in rats and mice when they are exposed to sort of toxic things. Skeletal tend to be the things that manifest. In doses in rabbits, doses of 40 times the maximum human dose were teratogenic. There was an increased chance of neural tube defects. And the no effect dose for embryo fetal development was about 11 times the maximum recommended human dose. So that's a really big sort of leeway there. So despite increasing use, there's still relatively limited human pregnancy data. This was a systematic review that was published over 10 years ago, and it came from, again, from Israel, Scandinavia and the US. 180 children with first trimester pregnancy exposure to methylphenidate. There were 4 children with major malformations. No significant association with major malformations, although interesting, they were cardiac. So, because there's always been this concern that they're cardiac defects, but we also know that cardiac defects as a group are the commonest. So about 1% of all babies with background risk will have a cardiac defect. So probably not a huge flag there. Okay. I'll go through. So methylphenidate and amphetamine, this was just a more recent study. And again, a really large number, no particular increased risk for amphetamines or for any malformations and not for cardiac malformations. And again, reassuring really for methylphenidate as well. And I'll skip that. So there was a slight increase in the risk of cardiac malformations with methylphenidate, but not amphetamines. So we will still, if we see someone on methylphenidate, we'll still say, look, probably there's more data about amphetamines, but if you're well and stable on methylphenidate, we don't think it's a major teratogen, and you need to weigh up the risks and benefits of alternate strategies. But, you know, we wouldn't be putting the fear of God into someone if they were on methylphenidate and wanted to stay on it. And again, there have been more reassuring studies now on methylphenidate. And again, cardiac stuff. In the 2020, the TGA issued a warning. And this again was a more reassuring one that came more recently from the US and did not show an increased rate of major malformations with dexamphetamine or methylphenidate. So that's reassuring. So I might just this is just more neurodevelopmental stuff, but again, not particularly concerning in terms of longer term neurodevelopmental studies. And just, and as I said, modafinil is a sort of off-label use for fatigue associated with MS and ADHD. It's also used for narcolepsy. There was some concerns about it being used in pregnancy because there was sort of a submission from the registry. But again, there were sort of a few birth defects in a very small study, but again, not particularly, not something that you're going to be putting the fear of God into someone, but you probably wouldn't be necessarily recommending someone go on it when they're planning a pregnancy. And there was a more recent study that did suggest of 133 pregnancies, and there were 3 children with a major malformation, which is not particularly different to the background risk. So, as I said, none of them are associated with a significantly increased risk of birth defects, limited longer-term neurodevelopmental data, strongly heritable. You know, you need to consider the clinical context, what's the risks of an untreated disease, psychiatric comorbidities, and, you know, what does it mean for the mother not to be able to work, not to be able to drive to work if she's got narcolepsy, and that's really, really important. So I'm just going to just stimulants and breastfeeding, weigh up risks and benefits. Some women will cease stimulants if they're on maternity leave and able to, you know, don't have to be on it when they're working. Some find that they need it because they're sleep deprived and they've got a mood disorder. Dexamphetamine, we've got good data on. Methylphenidate, it's really low dose, so we don't think it's a particular problem. It's not a reason to discontinue breastfeeding. And yeah, so I'll just skip that. Modafinil, little information. There were very low levels in data, again, limited data, but there's been a couple of cases where levels were low. So just useful websites. We've got quite a lot of fact sheets. Bumps is really fantastic. It's British. Mother to Baby's American. And LactMed is really fantastic for breastfeeding. And that's about it. And that's us. And then I just have to bring it. Okay.
I actually have a quick question. Or does anyone have any questions? I wanted to ask about GLP-1 agonists and breastfeeding.
So basically, look, I mean, again, if they're large molecules, they're not going to get into the milk.
Okay.
And even if they get into the milk, they'll be destroyed in the gut. So we're generally pretty reassuring. But a lot of women, again, probably, you know, some women actually do lose weight when they breastfeed, but, you know, but we wouldn't be completely against it.
Because your appetite just increases so much when you're breastfeeding. And there was also another online question about guana fasting.
Yeah, look, we've got limited data. There's no particularly harmful data, but there's not very much data on it. And the Americans use a sort of GHB thing as well, slightly worrying, for ADHD, and we've got very little data on that. But I had a woman that was American and insisted on using it, but wouldn't take folic acid because she was worried about that. Whatever.
Debra, thank you so much.
Thank you.
Thank you so much for giving up the Saturday to talk to us today. And that concludes our day. So thank you everyone for giving up your beautiful Saturday to be here to learn with everyone.